the only curative therapy to date for MDS is an allogeneic stem cell transplant. And as the age limit, chronological age is not an only consideration for transplant, and we are transplanting older and older patients, and now with the newer approaches to donors like haploidentical transplants, you have more availability of donors. Actually, there's a donor for almost every patient, right? So I just want to ask each of you about when do you refer a patient to a transplant center? What's your, when do you think a transplant is going to be imminent? And so can you comment on those aspects? I'll start with you, Rami.
Yeah, sure. So obviously, yeah, as mentioned, transplant is the only curative option. In reality, if you look at all patients with MDS today, less than 10% of the patients get that.
It's the second most common indication for transplantation for unrelated donors.
So from the transplant point, but from the disease point,
yeah.
like for example, in our database, we have like 3,000 patients. Only 200 got transplant over the last 10 years. So, and we are very aggressive in referring to transplant.
And it depends on where that patient is seen, right? And who sees that patient.
No, this is even at our place where we refer all the patients. So 50% of the patients even you refer to transplant and transplanted, mostly because of age and comorbidities actually, or of frailty. So the way we think of it, obviously, there had been several decision analysis models looking at the timing for transplant. So if patient is high or very high risk disease, the maximum gain of survival is to send those patients directly to transplant. So if we see patients higher risk MDS, we think of a transplant. When we see patients that are younger, lower risk, we think that they will probably need a transplant a little bit down the road. So I think the clear indication is the higher risk MDS patients, lower risk if they are younger or potentially candidates after a couple of lines therapy. The way I discuss it with patients is like it's a benefit risk analysis, right? So you are talking about 30 to 40% cure versus 10-20% unfortunately transplant related mortality, and a affection of quality of life over a year or two that needs some time. And that's how those decision models are based on, basically to favor early going to transplant or not going to transplant. So I usually try to put it in the context for the patient. If the patient, let's say he's 70, without MDS, what's the expected survival? With MDS, what's the expected survival, and how much they will gain in quality of life and time of, potentially, obviously. And I learned over time to present that to the patient, and every patient look at this a little bit differently, and they decide on that benefit risk for them.
And I think the challenge also is to identify the lower risk patients who have those adverse features we talked about earlier, and then refer them right away.
Right. But see, I'd like not to steal from your segment, but because of you mentioned low-risk disease patients, I want to make two comments about the transplant piece. First is that, yes, everybody with into and high-risk disease should be evaluated in some center, and certainly people, let's say, who have deletion 5 Q should actually have mutational analysis done, because those who have TP53 mutation may not necessarily have a good response to lenalidomide and may benefit from an earlier transplant evaluation. But on the other hand, do we have enough data to suggest that people who have adverse mutational features actually are cured by transplant? And there were data from this conference that told you that the chances of relapse or disease coming, is higher in people who have. Granted, it's not a reason to say I'm not going to send my patient to transplant, but I think this whole science is sort of evolving.
Yeah, as we get more genomic data, there may be subsets of patients who may not benefit from transplant, and we should not subject them to transplant because it's likely to be futile for this patient who has to go through all this morbidity. So that is also a challenge. So I think as transplant centers get more experience with genomic features that make a patient a poor candidate for transplant, that should be also incorporated into but I think every patient who is a possible candidate deserves a consultation.
Well, I think so too, because if patient suddenly worsens or takes a turn for where you really believe that you need to transplant that patient within a reasonable period of time, unless you've done the homework where you've actually had them have the transplant consult, you've actually looked for a donor, you've actually identified a possible donor, it's a very long period of time. So the sooner that you actually determine whether or not a patient has a donor, whether or not you decide to go down that route or not, I think is very important.
It's true.